Erev Tov, everybody. Good evening. We're going to get our program started in a few moments. So if you haven't found your seat yet, we ask you to do that. I want to thank everybody for coming out on this chilly evening for what I am sure is going to be a very fascinating and very challenging and a very important conversation about the ethics of end-of-life care. And we are very, very happy, thrilled to have with us Rabbi Michal Springer and Dr. Sandy Buchman, and I'll say more about them in a moment. I also just want to welcome everybody to our latest program in the Dr. Jeffrey Kramer Bioethics Initiative at TBS. And we are very grateful to everyone who helped support our Bioethics Initiative, Audrey and Neil Asbell, Kent and Kent, the Kramer family, and the Ravitz Family Kindness Fund, as well as many of our other donors who help us have excellent programs like this and bring in such wonderful speakers as we have tonight. And our bioethics program here has really become part of our DNA at TBS. Thank you. Thank you. Thank you. Now, I am here all week. That is for sure. Literally here all week. But we are looking forward to following up this program with other conversations coming up. And there's a flyer on the table outside about this. We'll be talking more. But one of the wonderful resources that Rabbi Springer pointed us to in looking at Jewish issues on Jewish views of end-of-life care is the Jewish Theological Seminary has a page on their website called Sage Voices that has rabbis and teachers from all streams of Judaism speaking to specific end-of-life care issues. And we're going to be having 2 sessions based off of those videos. The next one will be on Thursday evening, March 28th at 7:30 p.m., Jewish Ethics and Do Not Resuscitate Directives, DNR directives, and Rabbi Wexler is going to be moderating that conversation. And then on May 14th at 7:30, Jewish Ethics and Palliative Care, and I'll be moderating that conversation. And we'll be having those in our Rabbi Lindemann Lifelong Learning Center, and we hope that you can come out and take a look at those videos and part of those very important conversations. I also want to point out something else exciting for tonight. As I think many of you know, we record all of our bioethics lectures and put them up on our TBS website, tbsonline.org/bioethics. So if you miss any of the past ones, we have all of the programs up that we have done. Tonight, we are moving into a new stage of live streaming tonight. So everybody wave to the world back there. But specifically, we are live streaming because we were very excited to have been contacted by Cooper Hospital, the Cooper Medical School, I should say, of Rowan University, where we have Dr. Lori Winter, who's a member here, and Dr. Robert Hirsch, who are there watching tonight with their group of students, faculty and students from that Cooper Medical School of Rowan University. They're invited by the faculty of the Scholars Workshop there, which is a 4-year course that prepares future physicians to be actively involved in lifelong learning and provide students with skills needed to accomplish all of this. And they've gotten their students together tonight at Cooper, and they're going to be watching from there, and we're very excited to have them with us as well. So good to have you, everybody. Thanks for being here. Hope the pizza's good. I heard they bought you pizza. So that takes us to tonight. So our topic of end-of-life care and the ethics of end-of-life care is something that I'm sure has touched all of us in one way or another. We know that when the end of life comes, there are all sorts of emotions that come up, all sorts of issues, and many, many difficult decisions that can happen that we all try to make with love and with care and respect for our tradition and the wishes of our loved one and our family as well. And we know that these issues are very, very difficult ones that often speak to the core of who we are as Jews and to our love that we have for our loved ones during this time. And our hope for tonight is to engage in a conversation about some of these issues and the experiences from our speakers. Of course, we're not going to be able to get into everything tonight, but in our follow-up programs, we'll be able to delve a bit more deeply. So let me introduce our speakers for this evening. We are very happy to have with us Dr. Sandy Buchman. Dr. Buchman is an associate professor in the Department of Family and Community Medicine at the University of Toronto and practices palliative care medicine, providing home-based palliative and end-of-life care with the Temmy Latner Centre for Palliative Care in Toronto. He is currently leading a group who are building Canada's first Jewish residential hospice, which is called Neshama Hospice. And he was the president of the College of Family Physicians of Canada and the Ontario College of Family Physicians, and he currently is the president-elect of the Canadian Medical Association. And we're very excited to have Sandy here with us, and we're grateful to Greg and Julie Bannett who helped make the connection with us and Dr. Buchman. We're very happy to have him here tonight. And to my left, we are very happy to have Rabbi Michal Springer. Rabbi Springer is the founder and director of the Center for Pastoral Education at the Jewish Theological Seminary, which establishes relationships with hospices, Jewish social service agencies, and prisons and reentry facilities to allow students to learn the art of pastoral care. She began her career as chaplain in New York City's hospitals and became the director of the Department of Pastoral Care and Education at Beth Israel Medical Center. She returned to JTS in 2002 and now holds the Helen Fried Kirschblum Goldstein Chair in Professional and Pastoral Skills at JTS. And I'll just add, and I know I speak for myself and Rabbi Wexler and Kenner Cohn, all of us had Rabbi Springer as a teacher and a guide at JTS over the course of our educations there and have a chance to learn with her. And on a personal level, we're all very thrilled to have her here at TBS, have our teacher here at TBS to help facilitate this conversation with all of you as well. So here's how tonight's going to work, a little different than our past programs. We're going to begin with Dr. Buchman, who's going to give a presentation about the ethics of end-of-life care. And then Rabbi Springer is going to add her perspectives and speak about end-of-life care. Then they're each going to pose a question to each other about their presentations to get a little conversation going. And then we will open it up for everyone in the community, not everyone, we don't have time for that, but for those to ask questions here in the audience, continue the conversation, and after we conclude, there'll be desserts and coffee and tea in the Friedman Social Hall where we can continue the conversation there. So I want to thank everyone for coming tonight. It's wonderful to have all of you here. It's my pleasure now to turn it over to Rabbi Springer and Dr. Buchman, please.
Thank you, Rabbi Peltz, and thank you, everyone. It's really an absolute privilege and honor to be here before you. I've got such a warm welcome. This place feels totally familiar. I feel at home, and it's a really warm welcome to be at home. We just had an amazing dinner. I hope you all ate, because I've always learned that you can't teach a hungry man Talmud. All right, so now that we're full, I think we can go ahead. But it's really an honor to be here. And especially because it's the Jeffrey Kramer Bioethics Initiative. I thank the committee, I thank the group, I thank the family, and the sponsors of this. And to be actually on the stage with Rabbi Springer, wow. So like most physicians, we always make a disclosure, okay, about our potential or real conflicts of interest, and I don't have any to declare. But I put this slide up because, this is really in the spirit of sharing. You come up and you think, oh, you're an expert. You put doctor in front of your name and all of a sudden you're an expert. I don't see it that way. I really feel that when I come here, I don't know, I think I'm learning more than I'm giving. And I really see this as a way to share and to dialogue with you all tonight. So my objectives really here are to really illustrate three common ethical challenges that are experienced at the end of life by patients, and I should say by families, as well as by physicians. It's a dynamic. We're in here and we face the dilemma too. And sometimes I'm a patient or a family member as well. In Canada, we have something now called medical assistance in dying. I'm going to emphasize this. I'm going to describe how medical assistance in dying has changed the landscape about physician involvement in hastening death. This is maybe our most profound end-of-life issue at this time. And I'm going to put these sort of cases I'm going to talk about within a Jewish context for both Jewish patients, families, and for a Jewish physician. So I'd like to introduce you to Hannah. Hannah is 82 years old, an Ashkenazi Jewish woman who suffered from metastatic breast cancer. She was one of my patients. This isn't her real picture, but they're all true stories. She's of a Reform, liberal Jewish bent. But she has a daughter, Sarah, who is Orthodox, observant, a Baalat Teshuvah. Sarah follows her rabbi's every decision, everything that she says. So, for example, goals of care conversations. They what Hannah might want. And Hannah has told me privately and intimately that she does not want resuscitation. Her disease is very advanced. She knows that resuscitation will likely be futile. She doesn't want to suffer the indignities of resuscitation nor the breaking of her chest bone, and even the possibility of ending up in a vegetative state. But Sarah is her, what we call in Ontario, substitute decision maker or power of attorney for health. And Sarah's role comes in if Hannah can't speak for herself, if Hannah doesn't have capacity. Sarah won't respect her mother's decision to forego treatment. Okay? She's getting it from her rabbi. Her world says, no, you must do everything until natural life ends. Hannah doesn't want to be in conflict with her daughter. Okay? She doesn't want her last days to be filled with I don't want to be in contact with Sarah, in conflict with Sarah. Sarah and I have to get along. Okay? She's the main caregiver. We have to really work together to care for Hannah. And I'm also thinking about Sarah. Sarah's losing her mom. Sarah's in anticipatory grief. That's one dilemma. And here is Pearl. She's a 96-year-old Holocaust survivor, and she's a long-term resident of Baycrest Jewish Home for the Aged. So it's a massive facility in Toronto, I think the largest in North America. It's a hospital, long-term care, complex continuing care, focus on brain health and home for the aged. Pearl has advanced Alzheimer's dementia. She's in a vegetative state. She's nonverbal. She doesn't respond. She hasn't been able to swallow, and she's had an IV now for 3 weeks. So here's the scenario. It's Shabbat. I happen to be the doctor on call. I hear screaming down the hall as I come into the ward, just screaming, and the voice is yelling, "Get it in, get it in." And I rush to the room, and I see blood everywhere. Okay? And there are 2 nurses just sweating and trying to put a nasogastric tube, an NG tube, down Pearl's nose and not doing it. Blood everywhere. And her daughter, an Orthodox observant woman, screaming to get it in. I'm going to leave you with that dilemma there for a moment. Here's David. I'm a palliative care doc. I looked after people at home. I go into their homes. And David has advanced pancreatic cancer. And I knock on the door, and his wife opens the door, and I walk in, and David stands up, and he just doesn't say anything. He just rolls up his sleeve, and he shows me his number. And he said, "God took away my autonomy to choose whether I live or die, and I'm going to exercise my autonomy now, and I want you to help me die." We'll talk about David. I want you to think about those 3 cases as we go on. So, death in medicine. What features in death challenge us, our society, what challenge us is in law, and what challenge us in medicine? I put them into 4 categories. First, that prolonged and severe suffering that people have. When death happens at a young age, not just for children or adolescents, people in their 20s, 30s, 40s, 50s, 60s even now, okay, as we live longer and longer. Medical errors disturb us, okay, if death happens as a result of medical errors. And intentionally caused death, so whether someone suicides or they are killed. So what's so special about this end-of-life period? Well, there's many vulnerable patient groups, first of all. I work with vulnerable populations. Part of what I do is work with the homeless. I'm providing palliative care to the homeless on the streets, in the shelters. We actually have just started a hospice for the homeless in Toronto. They are often lower socioeconomic status. They have mental illness, often addictions, racialized. We also have a large Indigenous population, the First Nations of Canada, who have suffered through our residential school system and the traumas of colonialization and are often on the streets and suffering. So they have very specific end-of-life issues with little often in the way of social supports, like many of us are privileged and fortunate to have, families who care about us. Those people with multiple issues, multiple health challenges, multiple comorbidities, cancer, chronic obstructive lung disease, chronic kidney disease, heart disease, and they have diabetes, and they have them all at once. Then there are those difficult life or death decisions. Should I have cardiopulmonary resuscitation? Should I have resuscitation or not? Similar to what Hannah and Sarah are going through. What about withholding treatment, withholding, say, ventilation in an intensive care unit if someone's really coming near the end of their life? Difficult treatment decisions. Should we be really aggressive in treating that cancer? Okay, it's going to maybe cause you to have very severe side effects from, say, chemotherapy, or, and it's only palliative intent. It's only going to maybe give you a little more time, but the quality of that period of time, that quality of life might be really difficult versus, say, very comfort-oriented care, so that the time that you do have under palliative or hospice care may be positive. And then, of course, there's the question now of euthanasia, or medical assistance in dying, or MAID, which is now a legal end-of-life option in Canada. What's the impact on the family of all these issues? For example, about Sarah, or the poor daughter who was standing at the end of Pearl's bed and suffering, seeing her mother suffer. It's a very emotional time for those of us involved, so it's not just about the person. Many of you must have heard of Viktor Frankl, and Viktor Frankl was a concentration camp survivor, and he wrote Man's Search for Meaning. And there's a quote in there that I took out, and it says, "Man lives in 3 dimensions, the somatic, the mental, and the spiritual. The spiritual dimension cannot be ignored for that is what makes us human." When I approach palliative care, I'm often here, we call it palliative care, and here in the United States it's called hospice care. It's the same thing, hospice palliative care. We look at several domains of suffering that kind of merge together. There's the physical, of course. There's pain and many other physical symptoms, shortness of breath, nausea, etc., fatigue. There's the psychological and emotional aspects of having a serious life-limiting illness. There's huge social and financial impacts on individuals and families, many cultural aspects. And of course, there's the spiritual and existential suffering. So as a palliative care physician, I'm addressing all those domains. These were put together by Dame Cicely Saunders. She was a nurse, a social worker, and a physician who in the 60s had a Holocaust survivor patient who had cancer and began to write about total suffering or total pain. So, anybody heard of this, a good death? Is there such a thing? Can we actually achieve a good death? Maybe it's just a recent sort of luxury. Last 50 years or so, with the advent of such incredible medical technology, that we even could conceive of it. Some of you in the audience may remember when such a thing could never be considered a possibility. But there's lots of ambivalence about death here, even to see you out here. A lot of people don't want to talk about it in our culture. It's something taboo, and we don't deal with it till we're forced to at the very end. And is this a legitimate goal of medicine? We're always trying to stave off death. So who decides? Maybe a good death is an oxymoron. What about dignity? What is dignity? Do we have a common understanding of what a dignified death is? Is it self-defined? Is my dignified death the same as yours? Do I own my own death? Is that a benefit of our strong belief in the value of autonomy that we in the West so value? We're all about the individual, and the individual has rights, and the individual can make decisions. Do I own the death? Do I have a right to die if I so choose? And now we do in Canada with a physician's assistance. So you do have. Do I have a duty to die? What if I feel that I'm such a burden on my family and my loved ones? And I really want to be out of here because the pain of being such a burden on them is incredible. Can I control the manner and timing of my death? And again, that is our new option in Canada. So I'm going to tell you first a little about medical assistance in dying. This was Bill C-14, which became law on June 17, 2016. It's an act to amend the criminal code and to make related amendments to other acts. Basically saying it took away the prohibition that prevented someone assisting suicide. That's basically what the law did. There was a long case of a woman named Carter who had ALS, amyotrophic lateral sclerosis, who very much wanted to die. okay? She found that her suffering was intolerable, and our Supreme Court granted her that right. It had refused another woman with ALS back in 1993, Sue Rodriguez, by one vote in our Supreme Court. This time it agreed, and this compelled the government to develop legislation that ultimately became law on June 17th, 2016. And I just wanted to review with you some of the eligibility, and I took this right out of the statute. So a person can receive medical assistance in dying if they meet the following criteria. They are assessed by 2 physicians or nurse practitioners who are independent of each other. And the criteria are, in A, they have to be getting health services in Canada. There's no medical tourism. 2, you have to be over 18. 3, they have a grievous and irremediable medical condition, and I'll discuss what that means. For us physicians or other healthcare providers in the audience, it's a legal term that we have trouble with. 4, they have made a voluntary request for MAID, okay? They cannot be coerced in any way. And that they have, number 5, they have fully informed consent. A person has a grievous condition if the illness is serious and incurable. They are in an advanced state of irreversible decline, so they have to demonstrate this decline in capability. That this illness causes them intolerable suffering, and they do not accept other treatments. Treatments are not acceptable to them, or they've had it. They've had enough. And their natural death has become reasonably foreseeable. It's not defining prognosis. It's just that death is likely as a result of this illness or maybe multiple illnesses together. So here I am. I'm a house call doctor, okay? I throw on my knapsack and I head out to see people. And I all of a sudden, I used to feel lucky that I didn't have to deal with this issue all the time. But my role as a palliative care doctor is to try to address suffering in all those dimensions, that total pain, that total suffering, whenever I can. And I often hear, "Doctor, help me die. I really want to die." But what I'm hearing is I say, "Doctor, my life has become intolerable." Okay? And so I listen. That's my clue, to listen to what their suffering is in all those domains. If you explore suffering, if you undertake that tact in hospice palliative care, you can reduce that wish to hasten death by about 80%. But so many people that we see are describing that. What else did I consider when I sort of thought, can I become a MAID provider? I considered my own death. What happens when my time comes and I may want medical assistance in dying, but I didn't offer it to my patients when I had the ability and the authority and the expertise to do so. I thought about my wife and my sons, okay? If I came home distraught after a difficult time, would I be able to share it with them? What if they found this objectionable? And I thought about my profession. Was my profession behind me? So just as in the US, you have the American Medical Association, we have the Canadian Medical Association, which I'm now president-elect. And this was long before I even knew about this kind of position. But the CMA took the approach that they were going to support conscientious objection to this, because so many physicians find this very objectionable and won't go near it. And they were going to support conscientious providers. In other words, they respected the physician's autonomy to choose, just like we respect a patient's autonomy to choose. And my last reflection was, as a Jew, can I handle this as a Jewish physician? How do I ethically respond to my patient's suffering at the end of life, especially now in this new world of medical assistance in dying? So we have lots of duties and obligations. So there's the flags of the Canada United States. That's the law of the land first and foremost. The one on, I guess it's your left in the bottom, the College of Physicians and Surgeons of Ontario, is my regulatory authority that grants me my licenses and disciplines me, etc. And I have to respect their rules. The one in the middle, the yellow one, is the Hippocratic Oath. And that was changed to actually require the utmost respect for human life from its beginning. I will remember that I do not treat a fever, chart, or cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. The one below that is the new CMA Code of Ethics that was presented at the World Congress on Medical Law and Bioethics in Tel Aviv last September. And the one in the corner is Tefillah HaRofeh, okay, or the Oath of Maimonides. I'm not going to go through it all. You can read some of it, but I highlighted in red what was important to me in considering whether I would participate in MAID was, may I never see in the patient anything but a fellow creature in pain. The Declaration of Geneva, which I think I forgot to mention up there before. The Declaration of Geneva came up as a result of Nazi medicine in World War II during the Holocaust. Physicians around the world got together and said, we have to raise the ethical standards of our profession, and develop this Oath of Geneva. It's recently been redone as well, and I highlighted in red, I will respect the autonomy and dignity of my patient to maintain their dignity. This was important to me as well. And I will practice my profession with conscience and dignity and in accordance with good medical practice. The CMA Code of Ethics has a number, it's prescriptive, but it's also aspirational, and they review many virtues that physicians should show. What's the virtuous physician? For example, honesty, integrity, humility, and prudence. But two struck out for me here, and one was about compassion. A compassionate physician recognizes suffering, understands and feels something of the unique circumstances of the patient, and is motivated to act and does act to alleviate suffering. But a physician also has to demonstrate moral courage. One who acts with moral courage communicates and does what they believe to be right and true, even in the face of adverse consequences. This spoke to me. We also had some fundamental commitments. Two, I'm going to highlight the commitment to beneficence, which I think is self-explanatory. And again, we see that commitment to patient dignity and autonomy. So putting them all together, start to look and reflect as a Jewish physician, what does Judaism say about hastening death? Is it permissible? My first reaction was, no, halakhically, there's no contest here. You can't do it. And then I began to realize it's true. And I thought about ethics, and I thought about halakha and the law. And ethics refers to the standard or yardstick, the general principles we are using to make our decisions. Ethics asks questions, what is the morally correct thing to do in any particular situation? And law answers a different question. What is permitted or prohibited by a particular society, and what is a person's liability for punishment? Laws may be just or unjust, ethical or unethical. And so I wondered about halakha. Does it respond adequately to modernity? Does it say the rapid changes that we have brought about by this technical revolution in medicine? For example, the whole question of assisted ventilation. Here we can withhold ventilation, we can withdraw ventilation or life support if it's not appropriate, if it's futile and may cause the patient harm. In Israel, that's become a different story. It's actually illegal to withdraw ventilation once it's started, so people can remain in this state, artificial life support, for years. Is halakha sufficient to deal with these complex issues we face in modern medicine in 2019? How does it deal, for example, with LGBTQT issues? Does permissible killing exist within halakha? There are different points of view, like most things. So I examined permissible hastening of death in Judaism. In Judaism, I learned that there is a right to life, or better stated, a right not to be killed. Can this right be waived? And if so, under what circumstances might be waived? What I found was the killing of someone who's innocent, in other words, not guilty of a crime, by himself or herself or others is actually not strictly prohibited, but neither is it permitted without good and sufficient reason. Medical technology has really changed the definition around death. Do we think about cardiac death, as many people thought? Do we think about brain death with the body still being alive? There's a case to be made that life should end appropriately when death keeps faith with the way we want to have lived. I'm going to talk more about that. It's about your narrative, your biography. You may be familiar with these terms, gossis and trefa. A gossis is that immediately dying patient. A gossis is alive and nothing can be done to hasten death. If you hasten the death of a gossis, that's murder. But a trefa is a person who will certainly die, in other words, a person living with a life-limiting illness, a terminal illness, but it's not known when he or she will die. And it turns out, I was surprised to learn, that if a trefa is killed, the killer is not liable to prosecution. So the gossis is alive in every respect, but not so the trefa. And Maimonides writes, quote, "If it is known for certain that he had a fatal organic disease, and physicians say that his disease is incurable by human agency, and that he would have died of it even if he had not been killed in another way." So what I got, and this is from Noble, who is a Reform rabbi who wrote about this, that Maimonides places an incurably ill person into some other category. In some sense, the person's life is compromised, and his or her death by human hands is not murder. So there were some Reform concepts that I looked into as well in this. Mita yafa, a nice death. It's like that good death. Is that possible? The Talmud teaches that for a condemned criminal, we should have a quick, non-humiliating death, okay? To be kind and compassionate even to a criminal. So if we are to view condemned criminals as our neighbors and compassionately provide them with a rapid and non-humiliating death, what then is our obligation to innocent life, which is suffering terrible pain and a humiliating death? Preservation of life is valued by our Jewish tradition as a really important mitzvah, but biological life is not a supreme value and does not override all other considerations. So euthanasia can be an option for someone who is in the process of dying and who is suffering unbearably, and that's what our law, our MAID law in Canada says. And Noble writes again, in extreme situations, the termination of human life is not a sin, but can in fact be praiseworthy. We are relieving that person of their suffering. So is the termination of life consistent with the preservation of the person as created, Tselem Elohim, in God's image? So, in the other words, does the continuation of the biological life violate the sacred character of the individual's life? Think about David. The Agadah, or the sacred narrative of a person's life, therefore becomes part of that halachic decision-making process. What is that person's story? What is their biography? So you may be familiar with the Agadah, or the personal narrative. This is their sacred narrative. None of our lives are identical with each other. Therefore, one case, what happens in that particular case is determinative. And I'm sort of thinking, halacha has to be a crystallization of Agadah. You have to understand that story. I always go to that story. Why did I call my new residential hospice Neshama? I am getting to the essence of who that person is. That is the philosophy of care. Who are they? What is their Agadah? Agadah looks at the person and determines the course of action that may be taken, while halacha looks at the situation and imposes the law. How important is it that life end appropriately and that death keeps faith with how we want to have lived? And I'll just conclude here with a quote from Kravitz where he said, "Where pain trumps life, where suffering cannot be controlled and recovery cannot be achieved, then if that patient feels that life is no longer worth living and the game is not worth the candle, there is no need to extend life. And indeed, there may be a need to shorten it." So let's go back to my patients, to Hannah. How did I deal with Hannah and her daughter, Sarah? I didn't want to alienate us, and remember, I was sensitive to Sarah's grieving as well. So I had Sarah consult a rabbi who at first insisted that Hannah have full resuscitation. And with Hannah's and Sarah's permission, I consulted the rabbi myself, and I shared Hannah's story. I shared with Hannah that she didn't want to live. She didn't want to undergo resuscitation. I stressed the importance of a compassionate approach to her dying, and the rabbi got it. Okay? And he recognized the leeway he needed. And we addressed Sarah's suffering in her loss of her mother. And Sarah came around and she let Hannah pass away peacefully at home without calling 911 and people jumping on her chest. And she died comfortably in her arms. Pearl, I'm walking into the room, remember? Blood everywhere. Her daughter screaming, "Get it in, get it in." I knew the daughter was really upset. This was not time for the discussions. The discussions about end of life need to take place long ago, and when Pearl was able to tell us what she wanted, what was her agada. I didn't know it. I couldn't get it. The daughter's hysterical. I had to do what the daughter wanted. I said, I'm going to try once. I'm going to try once. If I get it in, okay, it's over. And I did. And I was torn, because I succeed in getting in, so the crisis is over. The NG's tube, she can now start feeding. What did I condemn Sarah to? I prolonged her suffering, I am sure of it. She's probably going to end up with a feeding tube now and go on, as she is. Baycrest, unfortunately, is filled with this. David met all the criteria for assisted death to choose and control the time and means of his death. I respected his agada. I respected his dignity. This was his dignity. His last words to me as he told me to go ahead with the injection were, "Thank you for your compassion." I felt that this act of me helping my patient die, fulfilling his final wish, giving him his full autonomy over his life and death, was completely consistent with my purpose as a physician, relieving suffering. And then for a survivor to express this was that much more powerful. Toda Rabbah. Thank you.
Can you hear me? Yeah, thank you. That was amazing. So I will, I'll take you on a journey, and we'll come back, and we'll be in dialogue. I'm really grateful to be here to honor Jeff Kramer's memory and his passion for this work, and to be with all of you who are in a regular dialogue about bioethics. It's sacred work. The opportunity to be in this dialogue with you, Sandy, is very meaningful to me on many levels. And as I was thinking about it, I realized that I was brought back to the beginning of my work around end of life, which took place in the hospital when I served as a chaplain at NYU Medical Center and at Beth Israel Medical Center. And I spent a lot of time in the ICU with patients who were intubated and families who were making decisions about what should happen next. And in particular, I was often called in to be with ultra-Orthodox people who believed that every intervention was necessary, and medical teams that were distressed about these choices. And as a chaplain, I lived in between the cultures, because as a rabbi, I understood the religious concerns of the patients. And sometimes it was patients who were not Orthodox, who also had religious sensibilities about the sacredness of life. And as a part of the team, I understood the despair of the medical team that was concerned about futile treatment and the prolonging of suffering, and the way in which people not understanding that death was coming led them often to say, we have to do everything possible, as if they had the power to prevent death. there was a way in which death was treated as overcomable because, in fact, the technologies are so miraculous that many moments of when in the past people would have died are no longer death-defining moments. And so we're a little confused about how much power we have and how we use that power, and when do we say that power is not ours. So to sit here with you, who live in this world as a doctor, and not only that, but you are president-elect of the Canadian Medical Association, and you live in a country where certain decisions have been made about how doctors can be involved with death, and to be able to have this conversation from a religious perspective just means a tremendous amount to me. And I get to ask you my question later when we do our dialogue, but you'll notice that Sandy did a lot of religious work here in his presentation that most doctors don't do. So I'm not going to duplicate that. But looking at the core religious values in decision-making at the end of life, that's where I hang my hat. That's where I live. So in my early stages of working in the hospital, I often felt that there was a perception of a right and a wrong, and that the patients who were choosing to stay intubated and in place in this ICU, they were definitely wrong. The medical center felt they were wrong, they were draining resources, they were a problem, and they were often looking to me to find a way to help people make better choices. Now, first of all, as a woman rabbi, they were certainly not going to listen to me. But I also wasn't interested in fixing their perspective on life. But I did recognize that it was an untenable situation for resources to be used in this way, because it meant that other people couldn't come into the ICU. And it was taking an acute care situation and turning it into a long-term care situation. And so I was really pleased when I came back to NYU as part of an initiative that I was working on in helping people make good decisions at end of life, something called What Matters. And Rabbi Peltz mentioned the Sage Voices videos, which is part of the What Matters project. So I went back to NYU to train the staff in helping people select healthcare proxies and be active in decision-making. And I discovered that now, 20 years later, NYU had a special person whose job it was, he himself was Orthodox, and it was his job to speak to the Orthodox families and to serve as a liaison and to communicate to them in these situations that had been so problematic that they were free to continue care in this way. That was their choice, and it was a legitimate choice. They just couldn't do it in the NYU ICU. And so they would help them get transferred to a facility that is a long-term care facility for people on ventilators who are receiving support in breathing and being sustained. And I felt such a relief that this problem that I had encountered over and over again was being taken care of, because it was no longer a matter of saying to them, your religious values are wrong, your understanding of life is wrong. It's just a matter of how do we provide care for you that's consistent with your values and isn't problematic for our hospital in the way that we conduct ourselves and the resources that it drains to support you in maintaining life. It felt very elegant to me. Because life doesn't belong to us. So that's where I want to go. I want to talk about some Jewish values. And Sandy framed them in ways that are a little different from how I would frame them, but similar. We're certainly in the same neighborhood. So when I think about Jewish values around end-of-life care, I think about our name for God as Rofeh Cholim, God is the healer of the sick. Healing comes from God. And this is healing of body, healing of soul. When we die, that isn't necessarily not a healing. There is healing that comes in dying. Healing is mysterious, miraculous. An absence of healing, as we expect to experience healing, can be devastating. And even in that, we can experience unexpected healing that doesn't conform to our notions of what it ought to look like. We say to God, Ata chonen la'adam da'at, God, you graciously endow human beings with intelligence. And this value alerts us to the reality that we value doctors, we value medicine. There is a magnificence in the human partnership between God and healing. And medical technology is a blessing from God. It is the advancement of medical technology that has gotten us to this place today where people are able to live far beyond what was once possible and puts us in a situation where we have to make choices that we never had to make in the past when we didn't have those technologies and we didn't have those possibilities. And so we have to continue to remember that this discernment that God gives us as a gift is a gift which we have to value and treat with great respect. So choice becomes an opportunity and sometimes a burden. In the Slichot literature, the literature of penance that we say around the high holidays, we say, Haneshama lach v'haguf pa'alach chusa al amalach. The soul is yours and the body is your handiwork. Have mercy on your creation. And so this is where, in some of the way, the people you quoted, Sandy, I would differ. I really see life as coming from God and not being ours. And so playing around with ending a life is treading on holy ground. And I don't believe that we ever have a right to take anybody's life. I don't believe that the doctors who are participating in medical assistance in dying are taking anyone's life in the way that I just said, but they've entered into very complicated territory, and it terrifies me. So I will come back there, and that's where our conversation will go, because it has to. And so part of what's so meaningful to me in having this conversation is that you come literally from a country where this has become legal. And I live on the other side of the border, and I live proudly in a state where it is not legal, and I'm glad that I do. But I'm very aware that the presence in the country, in the United States, of various states where assistance in dying has become legal affects all of us. And I run a hospice clinical pastoral education program where I take clergy, seminary students of different faiths, and I place them in the hospice, and they provide care to people who are dying and their families. And I have watched the conversation shift as the movement towards the acceptance of assistance in dying has continued to gain momentum in this country, which it has been gradually over the years. I watch the conversation among the people who are dying shift because it has an impact on them. And that's the place where I believe that's what we need to address. So as Sandy said, and I'll go quickly through this because it was so eloquently put there, from Jewish perspective, since life belongs to God, we don't decide when we die. We don't hasten death. On the other hand, we don't prolong the dying process. We have no obligation to prolong the dying process. Now that's very ambiguous. Our sources come from a time before we had the technologies that we have, and one of the things that I love about Judaism is that we're always changing and growing with what's new, and the process of halakha is taking vignettes, really, from what was, and then reinterpreting them in the contemporary reality. So what does it mean to say we don't hasten death and we don't prolong dying? It's a very thin line there, and you're going to have conversations. I hope you'll go to the Sage Voices presentations that Rabbi Wexler and Rabbi Peltz are going to do, because you can get into the nuance of that. But our best understanding of what being alive means and what dying means is activated in that tension, in not hastening death and not prolonging dying. So from a halachic perspective, if I wanted to make more room for the assistance in dying perspective, I would say that it's in the neighborhood of not prolonging dying. That's the part that I think can be halachically generous towards assistance in dying. When people are feeling that their dying is being prolonged, and we don't have an obligation to prolong dying. But I'm not going to go there right now. So I want to do this through my personal story, because it's one that I know well. And so I can add some nuance to it that might be a little bit different. I don't know. You'll tell me if it works. So in hospice, the value is on comfort care, palliative care, comfort care. And we know that many of us are afraid about what will happen to us at the end of life. We are afraid. We are afraid that we will be abandoned, and we are afraid that we will be in pain. Those are two main fears. There are other fears, but I would say overwhelmingly the fear of being left alone and abandoned in some form, and I guess I would throw in the fear of not being in control of ourselves, not being dependent, not being able to take care of ourselves, which is connected to being dependent on others and then being abandoned, and the fear of being in pain. So hospice as a philosophy is devoted to making sure that people are not abandoned and that people are not in pain. Can we do it absolutely 100% of the time? No. Sometimes you have to make really hard choices. Sometimes the choice is that you would go into some kind of medically induced coma that's not dying, but it's not pain. And there are people who say, I would rather not be alive anymore if that's where I'm going to be. And so I understand where those people turn and say, I wish that I had an alternative here. And from a religious perspective, we have to grapple with that desire when that happens. So let me tell you my two stories. The first is about my father. The second is about my mother. We're coming up on my mother's second yortzeit. So she's very present for me, as she's present for me all the time. And so is my dad. So my father died almost 7 years ago. And a couple of years before he died, he was rushed to the emergency room. And my brother got to the hospital before I did. And my father had advanced dementia. And my mother was my father's primary healthcare proxy, although at the time that this happened, she was developing her own dementia. And I was the secondary healthcare proxy, and I had had many, many conversations with both my parents about their wishes. So I said to my brother, please just make sure that Mom signs a DNR as Dad gets admitted through the emergency room, because that was my father's wish. So my brother said to my mom, we should sign a DNR for Dad, and my mother said, what? And so my brother called me back, and he told me my mother's response, and I said, okay, don't sign the DNR, but Mom and I have a lot of talking to do. So then I realized that even though my mother had been fully involved in these conversations, first of all, her own dementia was affecting her, and second of all, the gap between theoretical conversations and being in the moment where you have to sign a piece of paper was just too great. And even though I thought my mother understood where my father was in his life and what my father's wishes were, it wasn't true. And so I began the conversation with my mother again, and frequently for the next 2 years. We would talk about how my father was at the end of his life. My father didn't want any treatment. And my mother could say, yes, I can see that, but I love him. And she could talk to me about how much she loved him. And as it happened, which it often does, even though my father was dying bit by bit, he was still able to walk around until one day he aspirated. And in the course of an hour, he ate a cookie, he was happy, and then an hour later, the aide called me and said, "Your father's non-responsive. Should I call 911?" And I said, no. And we were very fortunate that my father was in his apartment when it happened. He lived in an assisted living facility. If he had been in a public space, the rule was that they would have had to call 911. We had experienced that before. But because he was in his own apartment, and because it was a private aid, she didn't call 911. Actually, she wasn't an aide. She was a nurse who came in that moment. And she didn't call 911, but I had to reassure her that I would be right over because it terrified her, because she felt she would be liable for letting my father die, and nobody wants to feel that. So I got myself right over there. I relieved her. I took full responsibility, and I didn't leave my father's side, basically. I took 1 hour out to do a medical errand that my father wanted me to do. But other than that, I was with my father for the next 36 hours. And my father died the next night, right after Shabbat came in. But the reason I say this is because all these conversations of preparation were necessary to be able to handle a long, slow death that then came to a very quick decision-making process. And if it hadn't all been very clear and talked about, if my mother in that moment had said, no, take him to the hospital, not realizing that he was dying, then it all would have been different. And my father's death was beautiful. My father was only in hospice for 12 hours because I hadn't been able to get him into hospice earlier, even though I could see that he needed it. I can tell you more about our health system that prevented it. But as soon as the hospice nurse admitted him, I called. He died as part of the same hospice that I worked with. So I called the rabbi and I said, Charles, can you please come? He was actually a former student of mine, so it was really beautiful. So Charles came. And then I called a music therapist and I said, the head of the department who also worked with me, and I said, could you send a music therapist? And my father had 2 hours of music therapy in the last hours of his life. And I was able to sing all my Jewish songs with my dad, which he loved and spoke to him. But my father was actually a saxophone player, and it was Jimmy Springer and the White Mule Band. And so I said to the music therapist, could you sing the swing music of the 1940s? And my father was listening, and she sang Sonny Boy. And when she sang Sonny Boy, my father lit up, hours away from dying, lit up. And my brother, who had been kind of skeptical about music therapy, said to the music therapist, can you sing that again? It was such a beautiful dying. With all of us there, we brought in Shabbat, we said Kiddush, we sat around his bed, and for my father, this was a good death. So my mother went on to live nearly 5 years after my father died, and she developed advanced dementia, and she and I had many conversations about what she wanted and didn't want. And my mother had an official aide through an agency. And one morning I got a call from the aide saying, "Your mother's having trouble breathing. I'm going to call 911. And I said, "Please don't." And she said, "I have to." And I didn't know, for all of the work that I had done, I didn't know that she would have to call 911 because of the agency that she worked for. And I said, "Well, when the ambulance gets there, I have to talk to them because I don't want them to take her to the hospital," because that was her big wish. She did not want to go to the hospital. So the ambulance came, and the ambulance driver did not call me, but I called back, and I said to him, "My mother has a DNR. It was plastered all over the place, and my mother does not want to go to the hospital, and I'm her healthcare proxy, and please don't take her to the hospital." And he said, "Your mother is not in cardiac arrest, which is what a DNR takes care of. Your mother is in respiratory distress, and I have to take her to the hospital." So against my wishes, she was taken to the hospital. It was Shabbat, and I don't drive on Shabbat unless it's an emergency, and this actually wasn't the kind of emergency that I needed to drive for. So the ambulance took my mother to Lenox Hill Hospital, and I walked through the park. I actually got there ahead of the ambulance. And I met the ambulance at the emergency room door, and I said to them, "Please don't treat my mother." So we got in the door. They had a mask on where they were compressing air to help her breathe. They took it off. The doctor came in, and he examined my mother, and he said to me, "Your mother, if we don't treat her, she will die within 72 hours. And I said, "Don't treat her." And the doctor did something really good here. He realized that I needed to be talking to my siblings. Now, I was my mother's healthcare proxy, so I didn't legally have to be talking to my siblings, but I did call them up, and I did tell them what was going on, and amazingly, my sister said, "But Mom seems so happy. I don't know if she wants to die." And again, I was kind of flabbergasted because I'd had so many conversations, but you can never have enough conversations because you always miss something. So I had to talk to my sister about my mother's wishes, and my sister said fine, and we called hospice, and I sat with my mother in a quiet room in the emergency area until they were able to arrange for hospice, and it was several hours, beautiful hours. I was singing to my mother and preparing for her to die, and she was really dying. And the hospice team finally got on board, and the ambulette came, and very sweetly they started to take my mother out, and they said to me, "Should we take your mother's blood pressure before we leave?" And I started to say no, and I said, "Okay, you can take my mother's blood pressure." They took my mother's blood pressure, and it was a little more stable than we had thought it would be. And I thought, that's interesting. We got her home. We put her in bed. I climbed into bed next to her, and at this point, I was so hungry. I hadn't eaten all day. And so at the place where she lived, they just provided meals, so I had some whitefish. I was eating next to my mother, and she turned over and she said, "What are you eating?" I said, "I'm eating whitefish." I said, "Do you want some?" She said, "Yeah." I said, "Okay." So we got her out of bed, and we got her to the table, and she started to eat. And then the hospice intake nurse came, and my mother failed hospice. They wouldn't accept her into hospice, even though the doctor had said she was going to die within 72 hours. But the little treatment that she got when they put that mask on her in the ambulance, that was the only treatment she received, but that treatment restored her. And so it meant that, first of all, she got into hospice a couple of days later, but I had to grapple with the fact that if my mother hadn't been treated at all, she would have died, which is what she wanted. But because she was treated, because I couldn't protect her from treatment that she didn't want, she then got what turned out to be 8 more months. So I needed to overcome my own desire for her to have died already. And this influences the way that I think about this, because had it been in my control, I was ready for her to die. She was ready for her to die. But it didn't work out that way. And after I overcame my anger at the system that wouldn't just leave her be, I was gifted with these extra months of life that I traveled with my mother. And it reinforced for me what it meant to believe that life isn't ours. We're not in charge of it. Now, do I think that my mother should have been taken to the hospital? No. And I immediately got her something called a MOLST, which is medical orders for life-sustaining treatment. And I don't know if New Jersey has a MOLST or a POLST. You have a POLST. Do you all know about it? Excellent. So had my mother had a MOLST, she would not have been taken to the hospital, and she would have died that day, and it would have been beautiful. But I had to cope with my fear about what the end of my mother's life would look like. And in dealing with that fear and dealing with her life as it was, I went on a journey with her that is a sacred part, both of my life and of her life. And somebody said to me along the way, you know, your mother would have wanted to live just for the sake of her family. And it's sort of a reminder that decisions about when we want to live and when we don't want to live, they're not independent decisions. They're interrelational decisions. When we sense that somebody wants us to live, we're more likely to make a decision to endure more for the sake of living. And when we sense that somebody wants us to die already, we're more likely to forego something or to accept assistance in dying because subtly we feel that it would be easier for others. It influences us. And that's where this conversation about so I believe very much in allowing people to die when it's their time. And I see assistance in dying as being on the other side of a barrier or a protective layer that we have. And as a rabbi, I'm very comfortable with allowing people to die when the time comes and not prolonging that dying process. That's where I end.
Is that right? Robert Springer, thank you. Thank you for your touching stories and sharing your personal stories about your patients. I was incredibly touched. Ultimately, somehow, maybe it comes down. Your mom had expressed when she was capable what she wanted. It turned out, fortunately, that you were able to get those 8 additional wonderful months with her. Okay?
Well, I don't know that they were wonderful.
Well,
they were complicated.
They were wonderful that she had quality, you were with her, and she was here. Had she had her way, or that her own autonomy was expressed, that wouldn't have happened, but she may have got her wish. So how do we balance that? What does Judaism actually say about autonomy? What does it say about, her right maybe to not want life-prolonging treatment? She ended up getting a life-prolonging treatment, even as brief as it was. It ended up being a life-prolonging treatment, although nobody saw that at the time. So, given that really it's up to God to decide if our life is taken or not, where is there room for her personal decision, expression of her personal autonomy? And I'm really interested in what Judaism says about that.
So from my perspective, Judaism is very clear that my mother had the autonomy to say, I don't want any treatment. Absolutely.
What about then allowing that to happen. So her wishes, in fact, were not respected.
Right.
By the system,
Right.
okay, what have you. Maybe it turned out it was unintended good consequence, so to speak, but her wishes weren't respected. And to me, that's an incredibly difficult issue. You know, in hospice palliative care, we seek at all times. If I had your mom at home and she was in respiratory distress, I'm going to have medications on board. I don't even have to call 911. We're going to treat her at that moment to relieve her suffering. And if she lives another day, another week, another 6 months, that's incredible, as long as she's comfortable and getting her wishes. So we look at it as a symptomatic treatment, ensuring her comfort. That's the goal, and that's the conversations that we have. And so it disturbs me, though, when my patients' wishes are not respected.
Absolutely. So part of the issue here has to do with dementia. Dementia, in many cases, is not seen as a diagnosis that makes you eligible for hospice.
Oh, really? So
if
different in Canada.
If my mother had been in hospice, we would have had hospice medications at home to treat her respiratory distress. But she wasn't eligible for hospice. And I discovered this because when the hospice nurse came to admit her to hospice, and they said, oh, this was just an acute episode that's now over, and she's not eligible for hospice because she doesn't have a 6-month diagnosis. Her dementia did not make her eligible. I had to then call on my connections and bring in another physician who would counter that and argue for why she deserved to be in hospice. And in fact, because she was so well treated for her respiratory distress, she got better and better and better over the weeks that followed, which is why she lived for 8 months. She lived for 8 months because of hospice.
We often find that. And so,
Yes.
But it's actually another ethical dilemma, is that why human beings with dementia aren't eligible for hospice care. To be honest, that boggles my mind.
Yes, yes. So I'm completely with you in that. For me, it's not the decision to end futile treatment, and it is the category of futile treatment. It's a different decision from a Jewish perspective if you end efficacious treatment, because that is really saying I prefer to die. But the definition of what's efficacious treatment and what's futile treatment, it's a gray zone. And we have to be respectful of that gray zone in talking to people about what they believe, given the best guidance that they've gotten, is efficacious treatment. But there is no religious obligation from a halachic perspective to undergo futile treatment.
And just, again, to follow up, I was presuming that when your mom made the request not to have active treatment, that she had capacity at the time. And that's what advanced directives or advanced care planning is all about, is expressing your wishes when you have the capacity so that the proxy or substitution maker can speak for you or express your wishes to the healthcare team at the time. So had she expressed her wishes when she had full and complete capacity?
So, yes, my mother expressed her wishes while she had capacity. And then it got complicated for me because in this period of the 8 months, my mother was so happy. And she would say, I'm grateful for every day. I'm so glad for every day that I wake up. And I started to think, oh, but maybe she's changed her mind. How do I know if her fear, when she had capacity, her fear about what dying would look like, influenced her decision that she wanted to not be treated? And now that she was in it and happy and relieved of all of her anxiety, she was now expressing a different wish, and she actually didn't want me to follow through on what she had decided when she had capacity. That was an ethical dilemma for me. And so I said to my mom, you're so happy. She said, yes. I said, so if your heart were to stop and you were to die, would you want me to bring you back? And she said, oh no, I'm ready to die. And I said to myself, this is the last time I'm asking her this question, because if she could answer this way, it's firm and abiding.
So
It's
I think I'm
different
gonna.
diseases.
Sorry, Sam.
So dementia's one, and fortunately she was healthy in other ways and could have a comfortable life. But when I think about Hannah with advanced pancreatic cancer and her suffering and her pain, etc., it's a different scenario. We can never know what the future will hold. Okay, we can never know it. All we can understand, I think, is our principles and make our best decisions that we can to guide our families, to guide our loved ones, to guide our healthcare providers. So it is. I get back to the Agadah. I get back to that personal story. Would Pearl, my patient Pearl, okay, who I gave a life-sustaining treatment. I put an NG down her, and all of a sudden, we were able to feed her, right, after all the distress. And she went on, to a feeding tube. And another 2 years of lying in bed, very advanced dementia, getting terrible bed sores despite the best nursing care, having pain that we could see in her, but that she could not express. That is also a choice that you make. You don't know what the future will hold. Your mother, thank God, had a comfortable, beautiful death and didn't meet that future. So this is where I'm just trying to paint a different, what would Pearl want? She was a survivor too, okay? What would her story have been if someone had taken the time to actually ask her and know her story?
So what I was very moved by in your going through your presentation is the soulful, loving holding of each life in its particularity. And I appreciate the freedom that you have to go wherever the person wants to go. And so as I've been thinking about it, I've been thinking about the difference between law and spiritual orientation. When you are in a country where you can legally make these choices, in some senses, it frees you up to follow your spiritual journey in understanding what it means to treasure the life that's been given to you and to balance what you can tolerate, what you can experience as the gift, and what choices you have when the gift becomes a burden. And I'm wondering if in your working with people who are dying, if you feel that the balance of that work gets tilted, pressured in the direction of foregoing life because the possibility is now available.
It changes the whole picture. You're right. Now that we have this option, people have the option to forego life, actually, and clearly hastening their death. And believe me, it's not something I welcomed, right? Selfishly, I was very content if I didn't have to face this issue with my patients. Okay? But the majority of the population sees this as liberating, as having the option to make a decision so that they don't have to undergo intolerable suffering. Okay, I recently had a patient, an eminent professor, cardiologist, with advanced Parkinson's disease. He had tried every treatment known to modern medicine. Everything was refractory. Nothing ended up working. He was left with uncontrollable shakes of his upper torso and his head and his arms. He couldn't do anything for himself. He became much more rigid. He couldn't turn over in his bed. He couldn't toilet himself. He couldn't feed himself. And he started to develop something called Lewy body dementia, a very early form of dementia associated with hallucinations. But he retained capacity, and it was just before the May legislation came out. And he asked me as I approached him to try to see what I could do. I mean, what could really palliative care do except be present with him, be compassionate and supportive with him? And he said to me, as he knew the legislation was coming, he said, "Would you talk to me about medical assistance in dying. And I've said, of course I would, because I'd gone through my reflective process by that time. And we have a poet in Canada, Leonard Cohen, maybe you know him. And Leonard Cohen wrote, "There's a crack in everything, and that's how the light gets in." And when I said that to him, that I would explore his suffering with him and this option, it was like he became illuminated. The light got in. He gave him a glimmer of hope. We all need hope. He knew as a physician what was ahead of him, that he had to be so dependent on others. He knew he was going to have years of just lying in a bed, in pain, with these tremors, nothing changing until God would take him. I cannot see where we can, I don't know, how can we stand that? How can we wait? If God gives life and he's the only one that can take it away, do we permit him to suffer like that? We see that in children. How is that a compassionate God? So he ended up being eligible for medical assistance in dying, and he died the most peaceful death I have ever seen. And he died happy. He had been seeing a geriatric psychiatrist for his depression, and as soon as we gave him the option, his depression lifted. I had the psychiatrist actually review him again because I couldn't believe it. He wasn't condemned. And I guess that's what I struggle with, okay? That's really gets to me. And do I want that for myself? Could easily be each one of our own stories.
So I'm going to jump in here and say thank you to Rabbi Springer and Dr. Buchman. And we have some time for some questions, some comments. Rabbi Wexler will be on that side of the room with the microphone. I'll be over here. If you have a question or a comment or something you'd like to add to the conversation, raise your hand and we will do it. And I will go to Dr. Lee Brooks. Here, do you mind?
Thanks for a great discussion, but it was all about old people for whom life was going to end at some point in the relatively near future. Children are a completely different ballgame. We don't expect them to die. There might be children with a congenital problem that have a reduced life expectancy, or a disease, or who've been in an accident and there's been a sudden issue. You're not dealing with children of the patient, you're dealing with the parents of the patient. So how does that affect your approach to the family and to the patient?
Are you asking each of us?
Oh, sure.
Is that on? I worked on a pediatric neurointensive care program called the Institute for Neurology and Neurosurgery that was created by Dr. Fred Epstein, Alav Shalom, and worked with a lot of kids who were dying and their parents. And I actually think it's very similar. The emotions run higher. The sense of how could this be is more intense. But the children were often able to say, I don't want more treatment, or I'm willing to have more treatment, and brought a lot of wisdom if they could be treated as human beings who were in conversation about their lives with an acknowledgement of the possibility of their death.
I work with kids too. And that's why I kind of brought up what troubles us in medicine, law, and society. And of course, it's the death or the ongoing illness of a young person. It does kind of depend on the age of the child. Do they have the capacity to make decisions for themselves? And many young people do. Many adolescents do. They really understand, and we give them that right often. They have the right to accept, a Jehovah's Witness child may not accept a blood transfusion and has the capacity to refuse them, as an example. So we can and we must involve children in the conversations if we can. If they have severe developmental disabilities, if there's a condition where they don't have the capacity, then yes, it's the parents, it's the grieving parents as they're grieving through this period that need the most compassionate of care, the most understanding, the most time. They need a hospice palliative care approach to ensure that their child has every comfort. Hospice palliative care is active treatment. It's really important. It's not, oh, you know, we've done everything we can, now you're off to hospice palliative care. We must understand that this approach is very active treatment, treating all their needs, as I mentioned, the pain, the physical symptoms, the psychological and spiritual, and it's about their family. Every patient I see, no matter what their age, it's also about their family and what they're going through at the same time. Hence my comments about Sarah, okay, as a grieving daughter. So this approach is entirely appropriate, and it is what we have for those children that may have life-limiting disease, illness, or disabilities, or even chronic disease.
Question over here.
So this question has to do with something that I think you only touched upon a little bit, and it's not about the individual, but it's about society. We spend an awful lot of money on feudal care, and so this gets to the point of justice in medical ethics. And I'm not going to ask this question to bring up a whole discussion about autonomy versus justice, but I just want to ask you both, what do you know about Jewish teachings? Is there anything in the halacha that gives us any insight on how we can balance that?
So that's a question for Rabbi Springer, not for me.
It's such a great question. We need to be able to provide the care in a communal way. It has to be viable communally. And I think that's part of that conversation about NYU saying, it can't be in our ICU. It's just not tenable. It compromises care for other patients. And it's hard when we initiate that conversation, but as a community, as a society, when we have the conversation and we say that these are boundaries that enable us to function, and when we go beyond that, we're all suffering. We're in the land of difficult choices. That's what it means. So that's all I can say about it right now. From a halachic perspective, we are juggling various values, but it is about us having a sustainable community and valuing life. And sometimes that's going to be in tension. So, as we say, tzarich chiyun. We have to keep probing that question. It's a more worthy question than my response.
So I have a question back here from the Cooper Medical students at Rowan University, messaged one in. And the question is, how do disparities factor into the decisions for end of life, especially for people without resources for hospice and or aides to care for them? So I guess asking about economic disparities between those who can afford this type of care, certain care, versus those who can't.
Well, let me say something from a U.S. perspective, and then we can have the Canadian perspective. One of the facilities where my interns serve is the Zicklin Jewish Hospice Residence, which was created by the Jewish community to provide a place, a home for people who couldn't die at home, but wanted to be in a home-like environment. So that's why it's called a residence. And specifically with a Jewish vibe, resources, rabbis running around, Shabbos, kashrut. And one of the things that I love about Zicklin is that there are Jewish people who are there, and another main population that's there is homeless people. people who've been living on the streets, who haven't had a home and are provided with a residence at the end of life. It is so beautiful, and it makes me love this country so much that there is a hospice benefit that even if we can't fix what causes the homelessness in the course of somebody's life, can give that person a home in order to die in a bed with meals and proper care. Now, that doesn't mean that everybody gets proper care at the end of life. There's a lot more work that we need to do to sustain people at the end of life so that they can get the loving care that we all deserve. And we're not there yet. But I just wanted to highlight something that is, at this moment, working really beautifully.
I'd first of all like to thank the Cooper students who asked this question. It shows it's a great school. They're beginning to talk about the social determinants of health and the inequities of access to health care for vulnerable populations. In Canada, we have a universal health care system. Everybody's insured. Everybody gets access to the same care. But there are inequities of access. So the ability of a person who is vulnerable, as I mentioned earlier, it could be those of lower socioeconomic status, those with mental health or addictions, and the homeless, and people of racialized minorities, et cetera, do not get the same access even in a universal health system. So I see this on a regular basis. I work in a palliative care program, as I mentioned earlier, on the street. I am in the shelters in the city, and we have recently developed a hospice for the homeless as well. It's only the second one in the whole country. So how do people get equitable access? This is an issue that all of us need to fight for, to ensure, because I'm sure you have one in your community, okay? But the vast majority of people out there do not have access in this country or in Canada to the appropriate kind of care. And they die young. The average lifespan in Canada is about 82 years. For people who are on the street, it's somewhere between 34 and 47, so say 40. Does anyone here know a disease that has this high mortality that cuts lifespan in half by 50%? It is critical that, and I think that's part of my Judaism, is part of that social justice, to go out there and ensure that all these people have compassionate end-of-life care. I call it the most downstream we can. Yeah, we really have to fix the upstream issues, okay, that lead to poverty and homelessness. But having said that, where we can't, we can and should provide the dignity of care to people who are so vulnerable.
I'm a medical oncologist and worked in palliative medicine for 35 years. Was involved with the lobbying for the hospice Medicare benefit, and off the side I can talk to you about some of its problems. I was on the board of the National Hospice Organization and then helped form the American Academy of Hospice and Palliative Medicine, and can sum up the opinion of American hospice and physicians by saying, until there's universal access to high-quality palliative care, we shouldn't legalize aid in dying. A quick question. You had in one of your slides euthanasia. You talked about injections. So does your law actually allow euthanasia, not just... So that's something that I don't know this audience knows the difference. But so in the experiments in Oregon and in California, Wisconsin, a few other states, I mean, you're allowed to write a prescription, but you're not allowed to give an injection that kills the patient. So I think I don't want people to leave and think that's their only option. And I think for me, the difference is also the irreversibility of that shot. Because you can always stop hospice, you always stop palliative care. And I think there is some danger in presenting these two topics without, I see palliative care is going to be talked about later in the series. But I don't want people to think that hospice and palliative care mean euthanasia, let alone assisted suicide.
Thank you. It's a really important comment, and I'll comment on actually two-part question. And the first is, how can we have a MAID law without having, full and complete access to hospice palliative care? I'm entirely in agreement of that. Our government didn't just go ahead and develop a law without having palliative care there. It came as a result of a Supreme Court decision that compelled them to create legislation before we had full access to palliative care. So we were stuck. That legislation was there without having the full access. I'm completely in agreement that we should be having full access for everyone, and we don't. So what we've done actually is we've leveraged the fact that MAID exists to really emphasize the need for full and complete hospice palliative care for all, first and foremost, and get the funding that goes into it. So that is really key. I think that people then, we need education because they can confuse the fact that medical assistance in dying is part of palliative care. Our Canadian Society of Hospice Palliative Care Physicians and all of in the Academy, et cetera, distinguish palliative care from MAID. And the World Health Organization definition of palliaire indicates very clearly that it's not there to hasten life. But now we have a different reality.
To hasten death?
Sorry?
To hasten death. Palliative care is not there to hasten death?
Correct. Palliative care, sorry, said it wrong. Thank you. Palliative care does not hasten death, right? It's part of that definition. Okay. My apologies. I think I'm thinking about 3 steps ahead on this. But I'm beginning to wonder even about that now, because now that it's an end-of-life option for people, is that distinction between what is palliative care and what is assisted dying, is that being blurred because it is a valid option and it is there to alleviate suffering, which is what palliative care is about. It's really about ultimately the alleviation of suffering, and this perhaps is that one really patient-centered treatment that alleviates suffering. So we're in a kind of a major debate. And right now, to be honest, the majority of palliative care physicians do not support medical assistance in dying. That's a minority opinion, but the vast majority of Canadians want it. Now, there's the oral ingestion of medications, and there's the lethal injection of medications. In Oregon, California, and other states, they only have oral ingestion, okay? And there are pros and cons. There, in Canada, you have the option of both, the IV administration or legal injection. In the province of Quebec they only have IV administration or lethal injection. They don't even go for oral. There are issues. There's medical evidence to show there's more complications with the oral. It's much shorter. I couldn't even imagine prescribing oral and then, the patient gives it to their spouse to take if you're not witnessed or being there at the time. It's difficult too, but it's important to distinguish the two. But in Canada, there are both options. Actually, so out of all the things, there have been over 2,000 medically assisted deaths. Only 4 have been oral ingestion. So people are choosing IV.
Okay, we have a question over here. Can you pass the mic down?
I think that the conversation that you're having here is especially significant in the political arena that we find ourselves, where the concept of Medicare for all is becoming an issue of conversation in the United States. Understanding that roughly 80% of the total medical cost comes in the last 2 or 3 years of life, when you combine that with the government having semi-control over how things are done, it goes beyond even the religious view of things. If this will come to be, if it will come to be. And it was very interesting to hear how the people of Canada, who basically have this type of medical care, deal with those issues. I was wondering if there's any comments from either of you on thoughts of how we progress in the United States on these issues.
So people have sort of talked against the MAID argument that it's a cost-effective solution, right? That it's, well, if we have MAID and people get bumped off earlier, well, that's going to save the system a ton of money, right? Because most of our healthcare is spent within the last year of life. That actually has not been part of the meaning for medical assistance in dying Canada. We don't, we talk, cost is a huge issue. How do we save money? But most of that discussion is going on to the Choosing Wisely campaign. And if you choose palliative care, if we have the conversations for hospice palliative care, then people make usually very wise decisions. And palliative care has shown to be much more cost-effective than aggressive futile care and intensive care units and et cetera, everything that you're referring to that prolongs life in futility and often with quality of lives that people don't value anymore. They wouldn't value if they had the conversations. So our emphasis has really been on having the conversations, doing advanced care planning, having people really understand well what they want. We make healthcare decisions two ways. So when I see a patient and sort of trying to get what they want, there are two ways. I give them the evidence. What's the evidence for a particular decision? Okay, what's the basis? And then I explore their values, okay? And Rabbi Springer referred to this earlier. Who is that person? What are their values? Is it their faith? What do they value? Do they value dignity? Do they value being with their family and communication? Do they want to end up, say resuscitation sort of is partially successful? Do they want to end in a vegetative state on life support machines when they can't actually communicate with their families because they're in a vegetative state? Is that a life worth living? That's what I ask them. So when we get at what they want and have these conversations, that and providing them with sort of the hospice palliative care approach, that is where the cost effectiveness takes place. Very few people choose a medically assisted death. It's about 1% of all deaths. So we have to really keep that in mind. And with reference to the earlier question about vulnerable populations, this is a request of people of high socioeconomic status, high literacy, the educated, the CEOs, the people who want control of their lives, who had control of their lives and want controls of their death. So it's the conversations beforehand that are key.
I think about staying connected to our values. So in the United States, we tend to value people based on what we're able to do. Our performance leads to our merit. And when we perform less, we can feel less valued. And there is room here for people to feel that they're taking up space, they're costing money, and they shouldn't be. Overwhelmingly, people, there's a fear, I don't want to be a burden to my family. I don't want to use up resources. I don't want to cost something. And when we have the option to end our lives, when this is put into play, my fear is that it goes from being the 1% to being a much higher percent, which I think we've seen in places like the Netherlands that have been doing this a lot longer. We need to look at the dynamic and the impact that it has over time, where living to the end of our life as it's been given to us is somehow experienced as selfish by people who are going to have to take care of us in the messy phases of whatever life brings. That, for me, feels like the potential shift that starts to happen when you have the option of a neat death as opposed to the unknowns and the messiness that maybe we would be willing to tolerate if we felt that the people around us would embrace that. And when we don't have to, everything starts to change. And I don't know where it leads us.
And we evaluate with regards to that and the feeling of the burden in the presence of depression. Okay, so those kind of issues, didn't have that much time tonight, but that is actually addressed within the eligibility assessments.
So what I would
say
say
is
is
very key, and it's a really important point.
So you are less than a year out from passing this legislation.
2.5.
Oh, sorry, I got that wrong, 2.5. So if we could look into the future and see what does this look like 30 years from now, 100 years from now, then we would be able to have this conversation. It's not the care that it's being given right now when it's still this 1%. It's the impact that it has on all of the people feeling perhaps more of an obligation to consider it, and then where does that take us?
So I know there are more questions and more comments, but we're going to have to move to conclusion at this point. We are going to follow up this program, as I mentioned before, on March 28th with Rabbi Wexler, and on May 14th with myself. There are flyers that are out there on the different topics. And also, we know that this program, I'm sure, really hit home for a lot of people here and raised a lot of questions, a lot of issues, and a lot of concerns about how exactly we try to grapple with this in our own lives, with our family. Of course, we're here at TBS to help any way that we can with those conversations and thinking that through, both from the perspective of our tradition and also thinking about it, how it impacts the dynamics with your family. And we hope that this conversation is something that doesn't begin and end this evening, but it's one that we know we've been having with many families over the years here at TBS. We'll continue to have here with families, but also hopefully together as a community as well, to be able to help ourselves understand these issues as best as we can and try to reach decisions that are the most correct decisions for our loved ones, for our families, for ourselves as well. So I want to say a big toda rabah once again to Rabbi Springer, to Dr. Buchman, and thank you to all of you for coming, to our Cooper Medical students. Have a good night. Don't stay up too late. We do have refreshments in the Friedman Social Hall where we can continue the conversation and to have something to eat there. And I want to say thank you all very much. Laila Tov.